So please give a warm welcome to Courtenay.
Thank you. Baruch is always such a tough act to follow. Great job, as always. So today I'll be talking about healthcare professionals' moral distress. And I'm going to describe it. Well, let me first start by saying I have no relevant financial interest to disclose. All right. So I'm going to describe it as we currently understand it. And I put the word formative up there on purpose because it's really only been in about the past 20 or so years that we've studied moral distress. And it's really only been in about the past 5 years that the focus has shifted away from nurses onto other healthcare professionals. Then I'll transition into talking about some instruments and interventions, and I'd really like to stand up here and say, you know, we got it. We understand moral distress. We know how to test for it. We know how to intervene on it. It's not an issue. But unfortunately, that's just not the case. Our understanding of this complex phenomenon is still very much evolving. And then I'm going to wrap up with some examples from a study we conducted at the Methodist Hospital, and we looked at 2 different ICU units, very different cultures in both units, and we interviewed 31 different healthcare professionals of very different backgrounds. We had chaplains, surgeons, physicians, social workers, just about everybody you could name. And we were trying to get at some of the factors and triggers that underlines moral distress in these 2 units. So I'll talk a little bit about that. So what is moral distress? By a show of hands, how many people can relate to this first question? Sometimes I feel like we try to extend lives of people to such a point that they're suffering. Of those people who just raised your hand, how many people can relate to this sentence or question? Do you ever just know when the patient's outcome will be poor and that the interventions will no longer be beneficial? Is that a point in time? Okay. How many people can relate to this one? Sometimes I feel like we give up on patients too soon. Okay. It's about the proportions I was expecting. If you raised your hand to any one of those questions, you've likely had moral distress at some point. So what is it? This is sort of the classic definition right here. Moral distress is a painful feeling or psychological disequilibrium that occurs in situations when the healthcare professional reaches a judgment about the right thing to do but just cannot act upon it. And it's usually typified by this sentence. I think what we're doing or what we're being asked to do or what's happening to this particular patient is wrong. Now, I think it's just as important to say what moral distress is not. Moral distress is not the same thing as just psychological discomfort. If you have moral distress, you're going to have some psychological discomfort or psychological distress. But just because you have psychological distress, it doesn't necessarily mean you also have moral distress. To have moral distress, there must be some sort of constraint, an internal or external constraint, and I'll talk about that in just a moment. And the healthcare professional must have identified an ethically preferable course of action, but they just can't take it because of the constraint, the internal or external constraint. And I also think it's important to distinguish moral distress from the classic ethical dilemma. With the classic ethical dilemma, there are 2 mutually opposing courses of action, and the healthcare professional just doesn't know which one to take. Here, the healthcare professional knows which course of action to take. They know which one is ethically preferable. They just can't take it. Now, you'll see in that second bullet point towards the bottom, I've got a comment about jading and compassion fatigue and burnout and grief out, and there's been a tendency in research recently to just conflate a bunch of different concepts together. Throw in compassion fatigue, throw in jading, throw in ethical climate, throw in moral sensitivity, and call the result moral distress. And that's a problem. It really frustrates our research attempts, and I'll talk more about that a little bit later. So let's distinguish moral distress from some other things like burnout. Burnout you're likely to see in any work environment. Moral distress is uniquely applicable to the healthcare environment. Grief out, grief is just repeated grief and loss. Moral distress does not necessarily have a grief component. And in fact, the case that induces the moral distress does not necessarily need to be an end-of-life case. Jading, and I'm going to spend a little bit more time on jading on the next slide. This is where the healthcare professional becomes apathetic to the point of appearing uncaring or actually being that way. And some people maintain that repeated exposure to moral distress, sustained moral distress, leads to jading. And let me show you how. All right, and I think this little light isn't working too well. Can you make that out at all? Yeah, I'll try. All right, so what's happening here is this is a buildup of moral distress. This is when the healthcare professional is encountering a morally distressing case. They've identified an ethically preferable course of action and just can't take it. So the tensions escalate and frustrations escalate and feelings escalate. So that's that little line right there, the little escalation. But then the case gets resolved somehow or another. Patient dies, patient transfers, the issue is resolved, and then there's a drop-off in those psychological distressing feelings. So that's this little drop-off right here. But the theory of moral residue holds that the moral distress never really goes away. There's always this residual effect represented by that dotted line right there. And then the healthcare professional encounters case B. And in case B, there's, again, some sort of morally distressing event. They've identified the ethically preferable course of action and just can't take it. So again, you've got some tensions and buildup occurring over the morally distressing case. But then again, the case gets resolved. Patient dies, patient transfers, something happens, and then you've got the drop-off right there. Now, the theory of moral distress maintains that as the healthcare professional approaches case B, they're thinking about case A, and as they approach case C, they're thinking about case B and case A. So that what you've got is a crescendo, that little dotted line at the bottom that runs along the bottom. It's a moral residue crescendo. In other words, a cumulative buildup of moral distress. And what you should see is a desensitization from the healthcare professional. They'll withdraw from troubling cases. Maybe they'll conscientiously object. Maybe they'll quit the practice altogether. What you should also see is an increase in the intensity of subsequent interactions. In other words, there should be stronger emotional reactions with each new case encountered, particularly if the new case encountered reminds the healthcare professional about a case they've previously dealt with of the same nature. Here's the problem I have with this theory of moral residue. First of all, it hasn't been directly tested, to my knowledge. And second of all, we looked for it in our study. We indirectly got at it, and we didn't see it at all, actually. When we talked to the healthcare professionals, it was the younger, more inexperienced ones that said, I've got stronger emotional reactions. The older ones, the more experienced ones, the ones that you really should see the buildup, the cumulative effect of moral distress, you should see the crescendo. They said, no, I approach each new case as a clean slate. Now, I don't know if that's true. That's self-report, so that's a limitation. But it does suggest that maybe there's something a little more complex going on than what we've put up here. All right, so what are the root causes of moral distress? I'm actually going to return to this slide a little bit later, so I'm going to just briefly talk about it here. The clinical situations where you're likely to see some moral distress, the big one, futility. Where the healthcare professional feels that they're providing non-beneficial treatment, you're likely going to encounter some moral distress. I'm going to show you a lot of examples of that. Inadequate informed consent, hastening the dying process, the ones I've listed there are the big ones. And then I told you there must be some sort of internal or external constraint that prevents the healthcare professional from taking what he or she believes to be the ethically preferable course of action. Now, the internal constraints is that there's something about the disposition of the particular healthcare professional. Maybe they're meek. Maybe they're not comfortable talking. Prevents them from taking the action. External constraints could be site-specific, or they could be broader external influences, like broader policy or economic imperatives. So, for instance, we know that funding availability is obviously linked to staffing levels. We also know that an imbalance between care demand and suitable staffing does cause moral distress. We know that. Now, sometimes you will hear people say, healthcare professionals leave their profession because of moral distress. One time I read that as many as 50% of nurses leave the profession because of moral distress. And when you hear something like that, I think you should view it with a little bit of caution, because it's a little bit more attenuated than that. Let me show you how. We know that there is a budding relationship between moral distress and job satisfaction and burnout. In other words, we've got some studies out there, but they haven't been quite validated. There's a very strong relationship between job satisfaction, burnout, and actually leaving the profession. So that would seem to suggest a high likelihood of uncovering a strong relationship, or at least some strong links of some nature, between leaving the profession and moral distress. Oh, pointer is really dying on me. But we haven't found that yet. I can only think of one study, there may be two. that have actually definitively linked moral distress to leaving the profession. We know that organizational ethical climate, in other words, an organization's ability to acknowledge and respond to ethical challenges, is linked to moral distress. That's why some people recommend ethics education. They think that by providing extensive ethics education, we might be able to mitigate moral distress. There's a link there for sure. But that hasn't been linked to, thank you. Thank you. All right. Okay. So now we're on organizational ethical climate and moral distress. Yay. So we know there's a link right here. But again, it hasn't been definitively linked to turnover. Do you need me to go through the slide again? Or are we able to follow where I was pointing at? No? Should I do it again? No? Okay. I'll move on. Thank you. All right. So I said at the outset that there's a tendency to conflate some very distinct concepts. And I think the example I used was people throw in burnout and compassion fatigue and ethical sensitivity and call the result moral distress. And I said there's a problem with that. Right now, there is no central agreement on the key definitional features of moral distress. And that really complicates our ability to create a coherent knowledge base, and it really impacts our ability to develop instruments, since how a concept is defined matters greatly in the measurement of it. I think right now what you'll see in the next few slides is we've got several instruments out there. I think there are probably 50, frankly, and they're all measuring very different things. So I'm going to show you the big three instruments. The big one, the first and most widely used instrument to test for moral distress, it was developed by Mary Cooley back in 2001. She has 38 different items on here to try to get at some of the root causes of moral distress. I'm going to read a few for you. I work in a situation where the number of staff is so low that care is inadequate. Carry out physicians' orders for unnecessary tests and treatments for terminally ill patients. Assist the patients who, in your opinion, is providing incompetent care. So which of these 38 leads to your moral distress or creates your moral distress? And the advantages of this instrument is that it has dual dimensions. It measures both frequency and intensity of moral distress. It's been used time and time again with great success, validated, reliable. Limitations of it, it very much has a nursing focus if you read it. And it's pretty lengthy. It takes probably an hour, 45 minutes to an hour to administer with healthcare professionals. The other big limitation on here, I think, is that some of the items don't really reflect current practice. If you look closely, she's got quite an emphasis on the ventilator. And I think nowadays we have more, newer technologies that likely evoke even more moral distress, like ECMO and total artificial hearts, for instance. All right. So this is a newer instrument. The second instrument I'm going to show you, it's called the Moral Distress Thermometer. It's just recently came out, actually. They use it for diagnostic purposes. In other words, they bring it with them during the ethics consultation to try to identify the intensity of the moral distress. And they have healthcare professionals rate the intensity of their moral distress. Now, the benefits of this should be quite obvious. It's a visual analog. It's very easy and quick to use. It's also measuring real-time, in-the-moment moral distress, so you're not getting that cumulative effect, which is nice. Limitations of it is it's not linked in any way to root causes, so we can't really tell what's contributing to the high intensity of moral distress. And the other limitation I find with it is I think it's so simple that it's arguably oversimplistic. It may not be capturing some of the nuances that make moral distress the complex phenomenon that it is. All right, now the moral distress scale has been revised. It's actually about to go through another set of revisions, and the goal for the revisions was to broaden the goal of the applicability of the scale to other contexts and to other clinicians, while still maintaining the variety of root causes. We have to understand the root causes. The root causes are the key to developing interventions, and if we don't have a firm grasp of the root causes of moral distress, and we don't, frankly, then we're not going to be able to build good interventions to try to mitigate or stop or address the moral distress. So what do we not know about it? Frankly, we don't know a lot. We're still in need of cumulative knowledge base of root causes and their interrelationships. I just mentioned that in the previous slide. Root causes have not been explicitly explored with regard to interconnections between individuals and unit and teams and systems. Moral residue has not been tested, and I told you I have a few reservations about it. The focus has just recently shifted away from nurses. We do know that all healthcare professionals suffer from moral distress, all types. We just don't know the similarities and differences between the disciplines yet. We lack some instruments and we lack consistent terminology. So, what did we aim to do in our study? Now, I'm not going to go through all of our results because, frankly, I think many of the results are beyond the confines of this presentation. I will mention some of the results in passing, as I have done actually up to this point. I mentioned our result about a moral residue, for an instance. But what I'd really like to do in the next few slides is give you just these raw emotional quotes from the interviewees, the healthcare professionals that we interviewed. Because I think this is the best way to give you a very visual sense of moral distress, what it is and how profoundly it is experienced. So we set out with the initial premise that moral distress is a relational concept. In other words, it's experienced by the individual, but it's shaped not only by characteristics of them, like their values and their beliefs and their personality, it's also shaped by the context in which they operate, which includes the relational context, the interpersonal context. So we wanted to get at the interpersonal dialogue dynamic, the unit and team factors. So we gave the 31 interviewees in the 2 different units 3 cases that were identified as being potentially morally distressing in their unit. And we had them describe their interactions, basically describe the case from the very beginning to the end, and talk to us about particular interactions they had, when those interactions were distressing, and why. We also tried to ask them, what interventions have you used in the past that's worked for you? So the quotations that I'm going to be pulling from are in these areas that are highlighted in bold. And what you'll see is that interpersonal dynamic is sort of the undercurrent of all of the quotations I'm going to give you. Particularly, misalignments in goals and expectations, either between team member and team member, between team member and family member or patient, or between family member or patient and another family member. And that those interactions are the source of distress. That's the commonality in all the cases. But before I go into the example about providing non-beneficial treatment, which is the first clinical situation where I'll give you an example of moral distress, I do want to spend just a little bit of time distinguishing rationing from futility. Because I think there might be a tendency to think that the healthcare professionals, the interviewees, are talking about rationing, particularly in light of some of the other presentations given today. They're actually not, with the exception of one slide where they're talking about both rationing and futility, and I'll show you that in just a minute. They're just talking about good old classic futility. Now, how is futility defined? You know, there's a whole literature associated with how difficult it is to develop a substantive definition of futility. Here are several definitions. I'm going to show you a couple of examples from the interviewees. One is talking about physiologic futility, where she believed that continued treatment is not reliably expected to produce the intended outcome. And imminent demise. The continued treatment is not reasonably expected to allow the patient to survive till discharge. Now, rationing's been defined in multiple ways. Here are several definitions for you. The most common one, I think, is limiting expectations of healthcare resources even where healthcare is beneficial, and therein lies the distinction. The healthcare professionals are not talking about limiting beneficial treatment, with the exception of one slide. They're talking about limiting non-beneficial treatment, and that's very much a futility concept. Now, the likelihood of a medical benefit is a rationing criteria. And where the likelihood of medical benefit reaches the low end of the continuum on probability, low end of the scale on a probability continuum, it can be considered futility as well. So to that extent, there's going to be some overlap between rationing and futility, and I'll show you where that happens. But it's important to keep in mind that futility is patient-specific, where rationing is a communal decision about many patients. So I just wanted to set up with that little preface to provide a caveat. So here's your sort of classic futility quotes. So these came from our interviews. in one particular unit on providing non-beneficial treatment. It was a prolonged death. The patient had skin cancer on his face, and it's spreading down his neck. It's just black necrotic tissue, and we have to change his dressings. Yet the patient's family wouldn't be there. They didn't have to see him like that, and then the nurses, I cried when I did his dressing change. In the room, I was teary-eyed. It was so horrible, like his ear was gone, and it was horrible. But yet we would wrap it up because we had to keep it wrapped, and then the family wouldn't even have to see it. The family thought everything was fine. I wish we could just leave it open so they could see what it looked like, so they could see exactly what they're doing to him. This is a classic physiologic futility quote. The important part is right there at the end, what they're doing to him. She doesn't say what they're doing for him. And she's clearly pointing to the family as a source of her distress, or at least, this misalignment in goals of expectations between the family and herself. Let's move on to a quote with the physician. He was never going to survive. He would never have quality of life. Can he go home with a big console like that? Can he go home and get home dialysis, bring in a dialysis machine, an oxygen concentrator, oxygen tank, oxygen blender, and have a refrigerator full of tube feeds? This is imminent demise futility. Notice how visual both of them are. Now, I told you there's one slide that I think they're actually talking about rationing and possibly rationing and futility, and that's this slide right here. It's the context of transplantation. And let me explain why. Under conditions of scarcity, even beneficial treatment will be denied. And that's the case of transplants, right? There are just not enough transplants to go around. The demand greatly outpaces the supply, so some people who could benefit from a transplant won't get one. Now, the allocations of distribution of the organs could be done in a very explicit and ethically defensible manner, or it could be done in a covert and unsystematic manner. And what you see from these quotes right here is the nurse and the social worker think we don't have the allocations right yet. We just don't have it down right. 78 years old for a transplant when the overall life expectancy in the US isn't even that high. I'm not sure that's going to be able to continue. An 85-year-old accepted for lung transplant. I'm not sure if that's, so she clearly thinks age should be a contraindication to transplantation, but she's also pointing out the likelihood of a medical benefit. And when you read the rest of the quote, you'd actually see she's talking about both rationing and futility. Then we see the quote of the social worker. She never should have been a transplant candidate. Regardless of my recommendations, regardless of my professional knowledge and the purported respect that I am given, to be ignored in the most significant cases is very frustrating. So she clearly thinks that psychosocial contraindications should be given greater weight. But she also mentioned something very, very important. You see this idea of feeling ineffectual? She says, regardless of my professional knowledge, to be ignored. The idea of being ineffectual when you're trying and trying and trying to get through to the team or get through to the patient or the family, that came up in every single interview, completely unprobed. So I think that's a big area where there's distress, is just the hitting against the wall. Now let's shift gears away from examples about rationing and futility, and I'm going to show you an example about inadequate informed consent, which is another big clinical situation that's been identified as being potentially morally distressing. Now recall that for an ethically adequate informed consent, the information must be provided to the patient. The patient must be able to comprehend the information provided. They must voluntarily decide to undergo a procedure and articulate a choice. Now, I think this slide is particularly interesting because the surgeon and the physician and the nurse are talking about the exact same patient. And they're all talking about the informed consent dialogue. Yet their experiences are so different based on the interactions they had with the patient. The surgeon. So when I first discussed the therapy with them, I presented it in stages. So let's get past the first stage. Let's save your life and stabilize you. But you have to understand that once we put this in, you're going to be on this therapy a while you get better. I went over all the risks and benefits, and he seemed to be extremely educated about it. He had experience with something like this particular device before. The intensivist. He kind of had informed consent, but not so much. I think the patient was a truck driver or something. I don't think, I mean, he was a nice enough fellow and he had some native intelligence, but he simply was incapable of having an informed consent. So who was right here? Either the patient had informed consent or not. Maybe they're both right. Look at the nurse's quote. Sometimes I don't know how much educated people can hear and process about their condition. We can give you a new heart. Okay, fine, I'll get it. I'll sign up here, but do you know what it really is? And even if we could explain for hours and hours and show them pictures, unless you have this experience seeing it and knowing it, it doesn't ring home to you. You don't know the agony and all the details of it and what's good and what's bad. So I find this quote particularly interesting because she says, you know, you can give them all the information you want, and they can understand and comprehend the information all you want, and you still can't prepare them because there are so many variables of uncertainty. We don't know exactly what your experiences are going to be or what your outcome is going to be. There's sort of a gamut, and you could fall somewhere along that continuum. So maybe the physician and the surgeon were both right. All right. I'm going to spend a little bit of time on this one because I think it really brings home that sort of interpersonal dynamic being the source of moral distress. So I feel like with these complex cases, we should frequently talk about them. The conversations come up when one of the nurses say, my God, can we talk about patient X? What are you guys doing? What are we doing with her? Only then do people say, oh, yeah, we need to talk about her. That really bothers me, the fact that we have to have our own distress signal about a patient for the physicians to say, oh, yeah, it's been 4 weeks since we've talked about patient X, huh? I don't know what we're going to do with patient X. Yeah, let's talk about her. So she's talking about the team-to-team dynamic. Then the nurse. Sometimes, you know, you agree with the family and you don't agree with the doctor, but you're in a precarious position about what do you tell the family. How far do you go with the family when you've still got the other part you're responsible for? We're put in the middle of things. Then we have the family that is completely oblivious, and the physicians want to keep going, and the nurses don't. We feel like our hands are tied. This is pretty representative of what we found in the study, actually. Physicians and surgeons very much focused on the dynamic between team-to-team members, in other words, a misalignment between team and team members as being the source of distress for them. With the social workers and chaplains and palliative care specialists, they focused on the disagreement or misalignment between family member and family member being the source of distress for them. And this, to me, makes sense. They're on the front lines dealing with the family. The nurses, though, the nurses focused on all. Family-family, family-team, team-team, misalignments as being sources of distress. This, to me, makes sense. They're, you know, at the patient's bedside dealing with the families and the patient. They're also as you can see from her quote, in the middle of things with the team. Now, I worry about this. I worry because it makes me think that nurses probably have more opportunity to experience moral distress because of the intensity and the frequency of the interactions that they have. Now, I don't know, because that wasn't really what we sought out to find. So we need to do follow-up studies to see whether that's true. But something is going on there. The other thing we noticed is that social workers and chaplains really tended to focus on their role as a professional. We actually went back through the transcripts to try to figure out how often they mentioned their role as a professional relative to other professions. It was 20-fold. They mentioned it 20 times more than the other professionals. And what I learned from this is, I mean, some of the examples they would give would be like, when the family does this, I feel like my role boundaries are crossed. When the team does this, I feel like my professional identity is jeopardized. And what I realized is that maybe, and I don't know if this comes through school or where, they're just indoctrinated with this sense of who they should be as a professional. But I worried a little bit because it made me think they have such a good sense of who they should be as a professional that they know the exact moment when they're being compromised. And so they might be more aware of the moral distress than other professionals. Again, that would require some follow-up studies to determine. But the fact that it came up 20 times more than with the other professionals made me think that they have a clear, concrete sense of who they are as professionals, or who they should be. So what did we see in all examples? there was a common theme. You're likely to see moral distress when there's maintenance of a treatment intervention that the interviewee thinks should not have been instituted or should have been instituted more carefully or differently, or should have been instituted but no longer maintained. Or when there's discontinuation of a treatment intervention that the interviewee thinks is an appropriate treatment and discontinuation is inappropriate, or discontinuation is inappropriate but should have been discontinued more carefully or differently. That happened in every case. There were some common themes for sure. This idea of misalignments at different points in time came up, as did this. Now, how do you know when you're suffering from moral distress, or if you acknowledge the theory of moral residue, when you might be suffering from moral residue? When we asked interviewees to describe their most morally distressing case, their eyes would glaze over, the tenor of their voice would completely change, they would crook their head back. It was like they were transporting themselves to the time and place in which the case occurred. So let me give you an example. I was telling this surgeon once, this was not here, this is when I was working at Cleveland Clinic, and I was telling a surgeon that I was interested in this concept called moral distress. And he said, let me tell you about moral distress. Oh dear. He said, I remember her name. I remember exactly what she was wearing. I remember she high-fived me before we went into the OR. I remember she was wearing god-awful purple nail polish that we could not get off. And I remember that the entire case, there was complication after complication. One complication would sprout up, we'd take care of it, another one would come up. He even compared it to the whack-a-mole game. And he said, when I was done with the case, I put my back up, and this is one of the best cardiac surgeons actually in the country. He said, I put my back up against the wall, slid down into a fetal position, and spent the next 6 weeks insisting on every aggressive therapy while the family and team begged me to stop. That's moral distress. If you're thinking about, you don't want to come to work, you're reluctant, or you're thinking of quitting, I think that's a telltale sign that you're suffering from something along the lines of moral distress. If you find yourself struggling to recall the miracle cases, I was surprised at how often the interviewees mentioned miracle cases as being a source of helping them through tough cases. Kind of gave them a reinvigorated sense of who they were as professionals and why they do the things they do. Suffering, physically or mentally. You discourage others from entering your field. Find yourself crying. A big one is if you find yourself avoiding or becoming detached from patients. This came up in every single interview, completely unprobed, this idea of being avoiding or becoming detached. These are pretty hard quotes to hear, but they're good examples of avoidance or detachment. Let me take a quick sip of water. First one's an intensivist, the second one's a surgeon. You know these people, the outcome's going to be bad. You end up trying to limit your exposure to the patients and have families because, first of all, after X days, you just run out of things to say. You run out of social things to talk about, the weather, the sports events, things like that, so you try to limit that. Also, it's depressing and discouraging when you know the outcome's going to be the same, as if you're watching The Green Mile, the movie, The Green Mile, and these people are on death row, just awaiting execution. You just have to limit yourself to step away so you can't really be human. Part of being a physician is to be human, interact with these people, and you can't really be a human being because you know they're on death row. Surgeon. You know, as surgeons, does it take some kind of special personality to do this? Do you have to maintain some kind of distance or be disconnected from your patient? Towards those last days, we kept a little distance from him. I wouldn't engage in the conversation with the patient towards the end. They are both talking about the exact same patient. The patient is dying. They're at their end of life, and yet they both distance themselves. Ironically, the end of life is the very time that the patient needs the clinicians the most, and yet we see two of them backed away completely. Two of them that were most intimately involved with the patient at the outset. So you can see how moral distress can impact patient satisfaction and arguably quality of care if this is representative of other professionals out there. So I painted this sort of doom and gloom picture of moral distress. Is what can we do about it? And I can only think of maybe 5, 6, 7 studies out there about what we can do to intervene on moral distress. They're mostly education interventions, and I have to tell you, they've had some pretty mixed results. I think if you're going to successfully intervene on moral distress, it has to be at both the system level and at the individual level, and that is because of ethical climate and moral sensitivity. Again, recall that ethical climate is the organizational practices related to ethical decision-making. Moral sensitivity is just borrowed from the developmental psychology literature. It's the ability to see an ethical situation, including how one's actions would affect others. We know that facilities that are able to retain or attract nurses have the capacity for them to process and resolve dilemmas. And we know that nurses who've experienced ethical conflict have had little or no ethics education, reported higher intention to leave. And we know when people can't consult ethics consultations, they tend to have higher moral distress as well. But at the individual level, if you can't cope, you're likely going to have moral distress. Now, we don't know much about what's going on here. We don't know how coping mechanisms are related to moral distress, but there's something. There's some sort of connection. So let me talk first about some of the education initiatives. And the goal behind the education initiatives is to try to teach people a little bit more about ethics, the idea being that if they knew a little more about it, maybe we could mitigate some of the moral distress. Teach them about some policies and some laws and how to think through an ethical dilemma and how to analyze cases. The problem is they've had mixed results. What has been more successful is developing ethics tools to try to intervene, which allow people to exercise their own moral convictions. So let me give you an example. We know that nurses will experience moral distress when they feel like they cannot initiate DNR conversations with patients and families. Yet Dan Salmacy has illustrated that, nurses feel quite comfortable initiating DNR conversations, and the majority of the physicians he interviewed felt that nurses should be able to initiate these conversations. So why not allow them to? If you allow them to, they'll be able to exercise their own moral convictions, and it will automatically mitigate a main source of moral distress. Another system-level intervention. So the first one was education. The second system-level intervention is debriefing. Here, it's usually led by, there's a debriefing session that's usually led by the ethicist. What's unclear to me is what the ethicist should actually be doing during these debriefing sessions and what is the marker of a successful one. But what I can tell you is that they should probably be regularly scheduled and you should leave with an action plan. Shouldn't be just a venting session. It only takes 2 people to vent. What makes a debriefing session added value is that it gives you an opportunity to develop an action plan. Have patients who do well come in. The healthcare professionals that work in ICUs, they tend to see horrible things every day. They're not able to see the good outcomes as frequently. So have the patients who leave the ICU and end up having a very good outcome come back in. It'll reinvigorate them. We do know they cling to miracle cases, so give them as many opportunities to do that as possible. One of the best system-level interventions is mentorship. They should be about on the same level. Doesn't do any good to have a director meet with the bedside nurse. They should have similar personalities, but most importantly, the mentor should not be judgmental. So let me give you a quick example. I seriously contemplated spiking a bag of saline instead of phenylephrine or whatever pressor he was on, and he would die. I seriously contemplated it. I was like, nobody would know. Nobody's going to miss a bag of normal saline. The pump is still going. There's no way they can trace it. The cameras can't see it. He'll have pressors off. He'll die. I'm seriously thinking about stuff like that in my head. But of course I wouldn't do it because I talked to the charge nurse and I was like, what do I do? This is so bad that we're doing this to him. I said, what would you do if you were in this situation? Would you push a beta blocker? If I gave a lot, he would have died. I was like, what do you do? How do you end his suffering when you're helpless to do anything except illegal? And she's like, whatever you do, you have to be okay with it at the end of the day. You have to be able to live with yourself and what you do. And to me, I couldn't live myself if I ended his suffering against the family's wishes. If I spiked a bag of normal saline instead of the pressors. Nobody would know, but I would know. Had the charge nurse said, my God, you're thinking about killing a patient, this nurse would have completely closed down. Instead, she used it constructively. She provided a safe environment and a sounding board for her. I'm going to skip this. The point of this slide is really just you really want to revisit goals as frequently as you can and to try to formulate consistent messaging as early as possible. Personal interventions. We talked about some of the system-level interventions. I'll quickly touch on some of the personal ones. I'm not going to read this quote because I don't think it's necessary, but a lot of nurses in particular tend to focus on what I call recalibration techniques. In other words, they would literally step back from the case, create some sort of heuristic or rule of thumb that would help them think through the case, and that would help determine what they should be doing in the case. So this one says she uses a headline test. She says, if I could see myself on the headlines the next day of the newspaper, I know that guides my actions. I know what I should and shouldn't be doing. This personal intervention was created by a nursing organization. It's basically ask yourself if you're experiencing moral distress, affirm it, assess it, implement strategies to initiate change. I think this is fine. It's all good and well, except for that it assumes that the nurse has a forum and has a support system that can help her develop strategies and could be a good sounding board for her. And if she doesn't have that, it's not going to help very much. But this is a very popular technique that's floating around right now. I think a big personal intervention that came up through our interviews was they like to talk to other people. Healthcare professionals found it therapeutic to talk to other people, but they don't like to go home to their spouses and talk to them because if they're in different professions, they can't relate. They like to talk to people who are in the trenches with them. And you know who they like to talk to the most? Chaplains. Came up in a lot of interviews. So chaplains in the room, this means you should be able to recognize moral distress and be able to address it because they're coming to you. The best personal intervention, this is one of my closing slides, is to develop in-the-moment techniques. Try to think and list the 3 cases that contribute to your moral distress the most. What are they? And then list out actions to try to break whatever it is you're dealing with in the moment. And run them past colleagues, test them, and see if they work. I really think this is the best way to get at moral distress. So I give an example. And I encourage people to think about techniques they might try that would be small things that might be able to break the source of moral distress while it's occurring. But I'm low on time. All right, take-home points. I've already brought up this slide before, but you're likely to see moral distress in these situations. I do want to conclude with one final thought. I don't think we should try to eliminate moral distress. I think it's an indicator of the sensitivity of the moral domain in medicine, and if we got rid of it altogether, we would lose our sensitivity. There needs to be some recognition of it. It doesn't mean it should go unsupported. It just means some of it should be there. And of course, you're welcome to share your stories if you'd like. I think we're running a little close on time, but I'd be happy to talk to people up here at the podium. What I'd like to do is acknowledge the many, many wonderful healthcare professionals for their complete candor. Without them, the study wouldn't have been possible. Thank you very much.